Hey guys, and welcome back to the Atlas Podcast. Today I have the pleasure of having my client on, Dr. Kelley Wright. Kelley's an IFBB Bikini Pro. She's both Team Atlas since, I believe, 2019, right?
Yeah.
And we turned pro together in which year?
2022.
2022. Yeah, so it's been almost a year and a half now since you've turned pro. And I wanted to have her on the podcast because she's a doctor and she's an IFBB Bikini Pro. And I feel that she would have a lot of valuable insight for you guys that are competitors, right? Because we have family doctors and they're against bodybuilding completely, right? We go for blood work, we get our hormones checked, and they're like, stop this, don't eat this much protein, right? Stop taking supplements. And I feel that she would offer a lot of valuable insight to you coming from both spectrums, right? As a doctor, as a bikini pro. So that's why I brought her on. I'm very happy to have her here today. And if you can introduce yourself a little bit.
Yeah, thank you. As you said, I'm a primary care physician and I work in Ontario, Canada, and I'm also an IFBB Pro. I'm also the medical director of 413 Medical Aesthetics, which we do cosmetics, injectables, IV therapy, that kind of thing. And I think that sort of being in all three of those different environments has really helped me to understand the bodybuilding world, as well as trying to integrate good evidence-based medicine into some of that bodybuilding space, just with competitions and what the body goes through and some of the challenges that the athletes have. So,
yeah, and it's very interesting for you also as an athlete getting to experiment and being kind of on the other end of the medicine side, right? So you can see different supplementations, how training affects the body, how blood work looks in athletes versus...
Yeah, I've been doing cosmetic injectables now for the past 7 years. I work with my husband, Michael, who's a physician assistant, and we do work on a lot of athletes. We are near a very popular gym in our area. A lot of bodybuilders, a lot of competitors are there. So understanding the changes of the face and the body as we deplete and go through prep and some of those cosmetic changes that happen. We also do IV therapy to support athletes during depletion as well as competition prep and things like that. So it's so far been an awesome experience. We're also instructors through a company called THMA. So we're instructors to new injectors that are coming on the scene.
And you're also a family doctor by practice, right?
That's right, yeah. Okay. So I have a focused practice in geriatrics, which has led me into a more of an interest, and we're trying to grow our practice right now into looking at things more like longevity medicine, things like that. So
that's why you guys look so good.
Thank you.
See your husband, it's crazy. 55 years old, looks like he's my age. I don't know if that's good for me or him. We have a bunch of questions that athletes have asked, and I think that you'll be able to give us some solid answers on them. So the first thing I want to discuss is semaglutide. I've talked to you about this a lot, and it's a big rage right now, just in Hollywood and even in athletes and just in the world right now for fat loss, right? And I've actually been using it myself, and I've had incredible results on it. And I believe you've also tried it too, right?
I'll preface this first of all by saying that I don't think any of this, when we start, is going to constitute any personal medical advice to people. Yeah. I just wanted to put that out there as well. Certainly my personal experience with some of the medications and some of the protocols that we've done they're based on my own personal experience, so I can speak to that. I did try Ozempic, about 4 injections. I didn't get a prescription. I'm not part of the problem with the world shortage. I just want to put that out there. I bought it privately from an amazing peptide company. I wanted to try it to see what it was like. I have a lot of patients, both obese and diabetic patients, that are taking it. I prescribe it several times a week, and I'm now seeing that there are some athletes that are trying it during their deplete phase.
What has been your experience with the clients that you've been prescribing it to from your medical practice?
So the initial indication was for diabetes when the first line therapies weren't working. So patients with very poorly controlled diabetes. So that's when it started to come on the market. And since then, there have been lots of studies, lots of evidence to suggest that there's improvements in cardiovascular disease outcomes, diabetic nephropathy outcomes, so that kidney disease, as well as the fat loss. And that was a side effect that they noticed. And so then it started to become prescribed off-label for obesity. So patients with a BMI of 27 or more. And so while some patients can get private insurance that will cover it for things other than diabetes, a lot of patients have to pay out of pocket if they want to try it. A lot of patients who are very motivated and they've tried tons of different weight loss modalities in the past and have been very unsuccessful. Ozempic has been very successful for them. I've been able to get patients off of their blood pressure medications because of their weight loss. They're starting to go back to the gym. They have fewer aches and pains and musculoskeletal complaints. So I think as a physician, I think it's a positive thing I know it's a very controversial thing. There are people that are taking sides. I think anything that helps a motivated person as a tool to lose weight, I think it's a great thing. And I've seen so many positive outcomes from it from other health perspectives. So
just from my experience, back when I was about 20 years old, I was 322 pounds. So I went through the whole fat loss process and I lost 140 pounds naturally with no help from anyone. I did it myself, training, diet, cardio, just the typical fat loss basics. I didn't use any help from drugs. I didn't take steroids. I didn't take nothing, and I did it. I find that sustaining that level of body fat after you've achieved your goal is very difficult for most people. And we see, I'm not sure if you know the percentage of people that actually rebound after they lose that amount of weight.
I mean, it depends on the way in which they've done it. So there are lots of very long-term sustainable ways in which they've done it. But I think it also depends on age. So when you were 20, you could do anything for 18 months. But if you're 55 or 60 years old, it's a different story. And I think that depending on what other things you bring to the table, I think sometimes you're going to need more help than just... And my hope is that when people are on it, we do complete obesity counseling. So we don't just prescribe it, say, see you later. There's a whole consultation that happens ahead of time where we talk about what are the strategies that they've used up until now. What was their ideal goal for weight? So some people have very unrealistic weight goals. And my ideal weight definition is what's the lowest weight you can sustain for the rest of your life. So if
While
you can
on Ozempic or just naturally?
Just in any form, whatever that is. We're not trying to get to perhaps their lowest weight ever. We're trying to get to their lowest sustainable weight. And while people are on Ozempic, and I think it's a great tool, what we're hoping is, and what our goal is, and what we try to coach our patients to do, is to try and look at more sustainable things that maybe seem too overwhelming when they were morbidly obese. Once they see some positive reinforcement, the psychology is starting to change, the hormone, leptin, ghrelin, all that what the GLP-1 agonists are starting to work on, then we start to look at lifestyle changes, sustainable, that 80-20 rule, where 80% of the time you're working hard to improve your lifestyle with that 20% where you can still enjoy yourself. You don't have to skip that New Year's dinner or whatever it is. So
you're using it basically as a stepping stone to be a motivator later on. So let's say like someone is 400 pounds and Ozempic helps them get to 200 pounds. And during that process, they were able to develop a healthier diet and learn the habits of going to the gym and doing their cardio. And eventually, in hopes they can lower the dose or eventually come off of it and sustain that and continue making progress without it, right?
Now, that's the million-dollar question, and I think that's what people are wondering right now in the healthcare community. Is this going to be something that people are going to take for life?
Are you able to do it? Are you able to take it?
So far, yes.
Yeah.
Absolutely. And I mean, there are some potential long-term side effects that we have to be aware of, things with pancreas, that kind of thing, which we would be doing regular blood work on anyway. So we would be able to look for those kinds of things. There are some short-term side effects that people, like nausea, constipation. If they're diabetic and they're on other hypoglycemic agents, we may have to reduce those. But as far as I'm concerned, they probably will stay on Ozempic, but they may get off of their 2 or 3 blood pressure pills and their other diabetes medications, their cholesterol pills. So if we're trading one for a mitful that they can get rid of in the future and also change some of their cardiovascular markers, then as far as I'm concerned, it's got to be a lifelong drug. And if they've tried going off of it or there's been a shortage, I had 2 patients come in today and one of them says, I haven't been on it for a month. I haven't been able to get it for a month. And he started to notice that he had that ravenous kind of mindset that started to come back. And it was a bad time of year because it was over Christmas. So he wasn't sure what it was, but he felt that he was starting to lose some control.
In my experience using it, once you come off it, the hunger comes back. So, as you said before, I feel like you would have to take it long term And I don't know how realistic it is for someone to lose a lot of weight and then be like, okay, I'm going to come off it and hope for the best that I've established these new lifestyle changes. Yes, you can continue in it, but I feel that you can, in hopes that you can take this drug for a long period of time. But as you were saying before, it's like a trade-off, right? If you need to take Ozempic for the rest of your life, but you can come off all of these other medications that you're taking, it's almost guaranteed a win. Plus, the number one killer in the States is heart disease, right? From being obese. And that's going to be more dangerous 99% of the time than taking Ozempic, right? So being obese and fat and overweight is much more harmful to your body in so many ways on your system than Ozempic would be, right?
Yeah. And I think it's the right treatment for the right patient at the right time. So we're constantly reassessing, what does that patient look like? Where are they at in their health status at any given moment? Is Ozempic risk now outweighing the benefits? We're constantly looking at that like we do with all their other medications, like blood pressure medications and things like that. So we're monitoring for all those things. Right now, I see it as a benefit for patients, and I've seen so many, not only is the evidence supporting these improvements in some of these risk factors, as well as these outcomes like cardiovascular risk. I mean, that to me is just an amazing outcome.
In all the studies, it's shown the risk of
cardiovascular outcome,
disease
decreasing
and
mortality
all these issues
rates.
is way lower on people on Ozempic, which is unbelievable. Right?
So,
and I started taking, it's first of all, Ozempic is a brand name for
That's right.
Semaglutide, which is a peptide.
That's right.
And the shortage is with the
device.
the Ozempic.
Actually, it's not even the medication, it's the clicker device.
Is it really?
And so the company that was contracted to do another medication that the company
Which medication,
also
yeah?
makes, it's called, I think it's Trulicity, I'm not sure. That clicker device is now being, that medication's coming off the market. Don't quote me on the actual medication, but now they're going to be using those clickers in the brand name Ozempic. So it's actually not the drug that's on back order. It's actually the device, that click pen device. So you can still give yourself Ozempic or Semaglutide if you want, as well as Wegovy and all those other medications that are very similar from that class. But you would have to give it to yourself through a normal injection, which a lot of people aren't comfortable doing for themselves. So we're making it as easy as possible to self-administer an injectable medication in order to have that kind of outcome.
So Ozempic is a peptide called Semaglutide, and it's just brand name.
Yes. Ozempic is one. It's a GLP-1 agonist.
There's Wegovy and there's
Mounjaro.
Yeah.
Yeah, which is the dual receptor.
Yeah, Mounjaro has Semaglutide and another component
That's right.
to it too,
So
right?
it's
So it's not
a
alone.
GIP, a GLP-1 receptor agonist.
And then there's Liraglutide too, which is brand named as Saxenda, and that was actually developed in the year 2000, I believe, and that was like their first Ozempic.
That's right.
And that one is, I looked at the studies, and that's actually the first one I started taking prescribed from a doctor, and it's a daily injection, and it's kind of like the first phase of this whole Semaglutide GLP-1 agonist thing, and I lost 20 pounds, and I felt like the effects kind of wore off. I was at the maximum dose, and I didn't really feel. I feel like I kind of plateaued at that point, and then I started taking the Semaglutide, the Ozempic, and my weight just plummeted down, like down another 20 pounds on it. And I felt like the effects of the Ozempic versus the Liraglutide, which is Saxenda, was astronomically different. And then I looked at the studies and I was like, oh, no wonder, because the Ozempic is the new phase drug, and the results in the studies, like they have charts where they show like a 42 or 48 week trial on, let's say, 500 people, and the people that are on the Semaglutide lost 18 or 90% of their total body fat, and the people on Liraglutide lost like 11%. So it's like double as effective. And it's a once a week or twice a week injection if you want to split the dosing. So there's so many negative stories on Ozempic, right? And there is. And whenever you mention Ozempic to anyone, like even a layperson in the gym or whatever, first thing they're going to say is, oh, it causes thyroid cancer. The number one thing that I've heard for people like bodybuilders in the gym, oh, it causes muscle loss. So they're taking like very small sections of a study out of context and trying to discredit the drug. And a lot of these studies, they're not putting bodybuilders on a study, right? They're saying, go to the gym, eat your protein, take your PEDs, whatever, and take Ozempic, and they're losing muscle mass. No, it's, if you're at home, right? Let's say you have a mom at home and she loses 50 pounds. She just does her little walking outside, doesn't really train. Whatever the method is for you losing that 50 pounds, you're going to lose muscle mass also, whether it's from Ozempic, whether it's from just dieting and not resistance training. You're going to lose muscle mass and fat too. So people are blaming Ozempic as a muscle mass or a muscle loss drug, they're calling it.
So the thing about these medications is they're not selective fat loss medications. None of them are. So it's body mass reducers. So weight loss medications. So people confuse that with lean body mass versus adipose tissue or fat tissue. So what these medications do is they reduce body mass. There's going to be a small percentage, I think it's up to 25% in, let's say, Ozempic, for example, where you're going to lose some lean body mass. But that's the same with any rapid weight loss strategy, whether it's gastric bypass surgery, gastric sleeves, those kinds of things.
But Kelley, even if you're at home and you just diet
Exactly.
and you don't resistance train, you're going to lose muscle mass.
That's what I'm saying.
You will. So
that's exactly my point.
It's not the fault of the Ozempic.
It's a rapid. So when you lose body mass, you're always losing a little bit of lean mass as well as adipose. Your goal is, and in bodybuilding as well as in regular life, is that your percentage of fat loss outweighs your percentage of lean body mass. You're not only losing muscle, but you can sometimes, at patients my age or older, lose some bone mass as well. But that's just part of body mass reduction, which is the goal. I mean, fat loss reduction and especially abdominal obesity, like waist circumference, those are the markers we use for cardiovascular mortality risk and things like that. So that's, to me, the most important thing is patients' waist to height ratios or their waist circumference to know if their cardiovascular risk goes down. That's what I look at in heart risk prevention. As far as bodybuilders go, I think talking about Ozempic kind of entering into the bodybuilding competition world is kind of interesting to me. I don't know what my sort of opinion is about it. It's just an interesting observation to see that there are some protocols out there that are starting to include things like these rapid weight loss strategies versus the, as you said, the old-fashioned way, which would be treadmill for 2 hours to lose the same number of calories. Maybe you have more experience in terms of with coaches.
So I personally think that the semaglutide and the Ozempic is going to be very big in bodybuilding soon, next couple of years for sure. And it's very new, and once people actually realize that there's a lot less negativity in practice with it than what's just being told, people are going to start utilizing more. And even with my experience in like my health, this is just a general thing for myself. So I did EKG tests, I did stress tests for my heart, I did all my blood work. I'm very meticulous with my blood work and I'm trying to micromanage it always. And all my markers are perfect. And I'm much healthier on the Ozempic than I was off the Ozempic. And it was a podcast with, I don't want to say names, one of the most famous bodybuilders ever. And he was on a podcast recently, a couple weeks ago, and he was asked, what do you think about Ozempic? He doesn't know much about it, but he just said, I'm against it because you should just focus on working hard and dieting and doing all your cardio. That's how you should lose fat, right? And I'm thinking it's kind of funny because why are you taking clenbuterol and why are you taking these other steroids to lose body fat, but you're vilifying one drug? Where do you draw the line? And this drug that's you're vilifying is FDA approved versus all of the trenbolone and all these things are not even approved for human consumption.
I agree. I think it's a tool that I think people are going to start using. Again, whether or not, like, I don't have a specific opinion about it right now. I'm just watching to see. I obviously don't prescribe it to bodybuilders. I don't really primarily have a lot of bodybuilders in my practice. But again, a prescription medication that's been studied, approved by FDA,
for
Health
human
Canada for human consumption versus all the PEDs, some of which are probably not the PEDs that they think they're taking. They don't have test kits necessarily. I mean, some of these upper level bodybuilders, but they're all tools, right? So you have a competitive edge, you want to win, you're in the pro league, you're going to use tools that are available to you. I would say on the scheme of things versus one tool or another, I think the relative risk, health risks, and again, it's very specific. Like you said, we're not talking about a general population, but for an average individual who's a healthy, relatively healthy bodybuilder, nutrition's on point, they're not doing crazy stuff, very fringe PEDs or anything like that, Ozempic might end up being a tool that their coach and the athlete discuss.
I think it's going to be big in this industry because, as you just said before, like it is FDA approved for human consumption, obviously for different reasons than bodybuilding. But the drugs that all the athletes are taking are not, prescribed by a doctor. They're taken underground 95% of the time, and there's a lot more.
There's some variability in the purity of some of the stuff.
Exactly. If you're getting it from a like an actual laboratory, or it's prescribed to you, you know that it's going to be pure, and you're not taking some random garbage made in someone's house. And I just found that funny because I was like, for a few reasons. One, because they were vilifying a drug that has been studied on for many years now with a lot of people, and they found that the pros outweigh the cons for most people, versus what they're taking is not approved by the government. And either way, the other reason I found it funny was because I don't understand the point of making your life more difficult when you don't need to, right? So the person said, oh no, you should be dieting and doing cardio and training and just suffering, right? Then why do you even have a car? Just walk everywhere you want to go, right? Make your life as miserable and as complicated and as difficult as possible if that's the route you want to take, right? Why? So for me, example, I lost 140 pounds naturally. Very difficult, right? I very hungry before bed every night. I did 3 hours cardio every day. I didn't cheat for a year and a half. Now I'm taking this stuff, right? My hunger level is way down. My blood work is flawless. My organ health is flawless.
Stress levels might be down too as a result.
Yeah, exactly. And I'm never hungry. I can go to bed, sound asleep, and I can work all day long. And I have a lot less pressure. I'm a lot less stressed. My body feels a lot better because I'm 40 pounds down, right? And I've seen all positives. People that vilify this drug without understanding it more, it makes no sense to me. Like, if you're taking steroids and you're telling, oh, you should be only dieting and doing cardio and not relying on this, then you're on both sides of the spectrum. If you're a natural athlete and that's a different story. I get that.
So that's what I was going to bring up is what would something like semaglutide or a GLP-1 agonist be considered a PED? Because it would be considered performance enhancing. I mean, I'm just kind of spitballing here. I'm just trying to understand like what, if people were deliberately taking it during a depleting phase or whatever, they would have to go in an open show. I'm just trying to understand what would they.
As of now, no.
Yeah,
right? But maybe in the future, because it is performance.
It's not a stimulant. It is performance enhancing. If you think about, your prep could be a lot shorter, or you could focus on. It takes, like you said, it takes one element of really hard work out of it. Doesn't mean you're not going to work hard, and I guess the other question is, genetics plays a big part, and more about this than I do when you see athletes and you see their potential and things like that. So I'm just wondering, would this open up the bodybuilding world or the competitive bodybuilding world to maybe people that you would have looked at prior to not think maybe they had the body type for it? Or
so it depends on the situation. So I had a client, she's 5'2", weighing like 160. And she, for the life of her, she was just binging, could not get her weight down. No matter what she's been trying for 2 years to like diet and do cardio and doing all that. It was also willpower, but also genetics, right? Because we'll speak into it, but there's a role. The reason that you get hungrier than maybe someone else, because there's hormones in your body called ghrelin and leptin, right? And those can be different with different people. So there is a genetic component to how hungry you are based on your hormones in your body that are controlling your hunger levels, right?
There's probably a lot of environmental factors as well that can contribute to that, lifestyle. And the genetic component might just be the family environment, that if you were raised in an Italian family, for example, where all you did was eat all the time. I mean, those satiety hormones might be out of whack just because you've been training them for so hard to be in the other direction. So I'm not sure if I can speak specifically on a genetic mutation, for example, that would be responsible for those.
For someone being really hungry and binging?
Yeah, that would be very interesting. Nevertheless, we do see these familial groups of patients, like family members, where they all look the same. They've all grown up and they all ate the same way. They all have the same type of lifestyle. They all ate the same types of foods. And even when they leave their family home and they go out they tend to have the same habits. But you're right.
The second you hear someone that can't diet and can't do cardio and stuff, right, you assume right away it's mental. But there could be some genetic component to it that could alter someone's ability to diet too, right? I mean, if someone's 800 pounds and they're just eating all day long, a lot of it is mental. But either way, with this girl, what we were speaking about, so she started the semaglutide. She lost 40 pounds. I can't even believe it. My whole life, I've never been able to diet. I wanted to compete. I wanted to get on stage. And I understand to get on stage, you have to work hard. This girl works like an animal. Trains in the gym every day, but she just had a problem with binging and really getting her hunger under control. And she wasn't healthy being 5'2" at 160, right? And she's down to 120 now. Her transformations, she has six-pack abs. Not taking antiestrogens, not taking clenbuterol, not taking SARM, not taking anything. She's already very muscular naturally.
Right.
She took the semaglutide, weights all the way down. We saw her blood work. Everything's perfect. It's sometimes she can't believe it that this was like the trigger point to really set her on the right track, right?
Yeah.
And yeah, even for me, when I lost my weight after I started bodybuilding, and I took every steroid there is, right? Because I was bodybuilding, I wanted to get big and lean in this. That's not a sustainable or reasonable route to go long term. You're going to have to come off the steroids. You can't take clenbuterol forever. It's not good for your heart, right? There's so many different things, especially as a woman. You can't be taking antiestrogens forever. You can't. It's going to be a lifestyle change. But and even as a guy, like I would take tren, right? I would get lean, I would get shredded, I would feel great, and then you got to come off it, and then you rebound a little bit, you feel softer. There's no long term sustainability besides hard work and like dedication, but for most people, that's not realistic for their whole life. Like you want to be 80 years old and be starving at night every night before you go to bed. Like for some people, it's not a realistic thing, and they're going to rebound, and they're going to get obese again, and they're going to fall into the whole thing. So for me, I felt like the semaglutide thing was a huge help. I'm traveling 40 weeks a year. I'm as healthy as I've ever been, and it's just a tool, like you were saying before, that really helps me stay on track. And I've lost 40 pounds, and I feel much better. So for me, it's a really good tool, and for me, it's a miracle drug because I've tried every steroid there is, and none of that is long term. There's none of that you can take long term besides like TRT or HRT, but at low dose. But it's still not going to really help you lose the body fat or reduce your hunger levels. So for me, it's a miracle drug, and I think it's going to be very popular in bodybuilding. And you had mentioned something too. We were speaking about it once, and you were thinking, you're like, it might be useful for some girls that, let's say, they do a competition, right, and then they want to take it a little bit. They want to take some of it after the competition so they don't rebound after the show, right? Because as you diet down, right, you get hungry, your body's more in a starvation mode. And then if you use that tool to come off of your contest prep, you come off the PEDs, and you start semaglutide, your hunger level is still going to be very low, and you're going to be able to reverse diet properly. And that may be a much healthier route than someone who tends to binge and gain 30 pounds after a competition, right?
I think we got to use healthy in air quotes there, because I think not to get too much into the whole body dysmorphic issue with that, but sometimes the weight that they are at on competition is not a sustainable weight either. So we have to also make sure that they have a healthy understanding of where what their goal should be for off season. And of course, every athlete's going to be different, whether they should gain 5 pounds, 10 pounds, 20 pounds,
I'm talking
whatever.
about the people that gain like 30 pounds in a week.
And I think you talked about this in your last podcast, which I thought was kind of interesting, because there is that whole psychological thing that happens as well, right? Because they suddenly have the freedom to eat whatever they want. They're not on the strict diet at the end or whatever they had to do to get to the stage. However, staying on something that's going to maintain a low body weight, I don't know where it would fit in just yet. I just thought it was kind of interesting. I know we were just kind of talking about it, just to see would it help with the cravings. I kind of thought more, somebody's in off season, for example, and they're doing really well, and you've got them building and you've got them on that type of a protocol, but now it's time for them to lean down. I wondered if that would be a more appropriate time to start it, because that's when you're really fighting the cravings, because you're like, wait a minute, I was eating 1,200 or 2,400 calories yesterday, and now he's got me down to 1,200 or
maybe
whatever.
Not that big of a gap. Yeah, I get your
point.
But
you're doing a quick kind of, depending on what when their stage date is, and on top of that, all their cardio and things like that. I mean, again, it's hard to say. I don't know if I would put a patient or an athlete de novo on Ozempic. There are some side effects we have to be aware of, short term. The long term ones I'm not too concerned about, right, in the context of this. There also have to be the right appropriate patient for that. If they have a history of that thyroid or medullary thyroid.
There's a few scenarios where you should not take that.
Exactly.
Right?
So, I mean, let's say they're the ideal candidate. It would just be kind of interesting. However, if they do have some side effects, can they afford to take a certain number of weeks off the gym if they feel rotten as a result of some of the gastric emptying, the constipation, the headaches that you can get from it, as well as the nausea. Again, there are side effects that you can mitigate ahead of time. You can warn patients, and I warn patients when I prescribe it. You could either have diarrhea or constipation. These are the strategies that we're going to do they're all related to the low gut motility.
And the dosing too. Like if you overdose it, you're not going to feel great, but your body adapts to it pretty quickly. In the first 2 or 3 weeks I started taking it, I didn't feel great. Like my stomach is hurting, right? Because you have the gastric emptying, slowing down, and
the acid reflux is quite a bad side effect.
Right now, I really feel no side effects on it at all. I just have the benefits in it. And as far as like side effects, where we sometimes think of like negative side effects as far as like your health concern, but it could also be like you're saying, just the way you feel, right? You can be like more tired. You can be your stomach can hurt. And you have nausea. But I feel like for me when I get tired on it, it's because I forget to eat. It's not because of necessarily the drug. It's just because I'm not hungry. And I'm like, okay, I kind of have a headache right now. I probably should eat some food. And the second I eat it, then I feel perfectly fine. So I think that's the only real side effect that I get. But
I see semaglutide creeping into this industry. I see that it's going to happen.
Yes.
It's come to Hollywood.
I mean,
it's there.
It's the perfect for the industry. Like it's like you're competing, trying to get shredded, and it's a very good fat loss, a body weight drug that doesn't have that many side effects. It's going to creep in. It's very new to the public, because it's been FDA approved for weight loss since 2017, and it started in 2010 as a obesity drug, but there's going to be protocols for it coming into the bodybuilding. It's without a doubt, in my opinion.
I think we've got protocols for some. We as in the collective, we as competitors, there are collective protocols for PEDs and things like that that are based on whatever. One coach said this works, another. I mean, it's just the Wild West out there. That's what I hope we have a chance to talk about that, because that's not regulated at all. At least there is some evidence-based protocols out there, mind you, for use in other things. But again, the goal is this seemingly the same. So again, without giving my opinion whether I think it's a good idea or not, it's interesting to me, and I think, like you said, you're going to see it coming into the bodybuilding world and being part of protocols in those higher level athletes.
And we've seen, I think Oprah came out a month ago or so on Dr. Oz, that she looks like unbelievable at her age, and she's a billionaire. She has all the best doctors and medical advice and everything, and she took the drug herself, right? And she's found unbelievable. She's had unbelievable results, and she's getting so much scrutiny. Oh, why are you taking this, and why are you doing this? And it's just like, I don't get it. For me, it's life changing, and it's going to change my life going forward. My sister took it, lost 60 pounds. She feels much better. No more back pain, no more swelling in her ankles and stuff like that too.
Which again is a tool to help motivate them to do healthy things, right? To get back to the gym if they don't go to the gym because their back and their knees hurt because of the weight or whatever. So I think that piece, I think, really needs to be there in patients who have literally tried quote unquote everything.
Example. My mom is the prime example for this. And the thing is, I can't do cardio and I can't go to the gym because my back hurts and my ankles hurt and my knees hurt. So if she lost 50 pounds, she would be able to get herself to the gym and be motivated to go. So,
or at least walk more or something, just move more, because really they've done tons of studies on mortality being shortened by inactivity. It doesn't even matter what their body mass index was. Patients that moved more live longer. That's just a fact. It doesn't matter if you're obese or you're thin. If you move more, exercise seems to be quite a high predictor of some of these risk factor lowering strategies.
Yeah, it makes sense too. I'm not contradicting what you're saying, but also there's not people that are fat that live to 89 years old. It doesn't exist, right? Everyone that's at that age is more slender, and not necessarily that they're fitter, but the obesity is the number one killer. And the issue with all the negative press around it too is because this Ozempic and the Semaglutide is going to disrupt a lot of industries. It's going to ruin all these. If everyone starts getting on Ozempic and it's very readily available for everyone, and you reduce obesity in the United States by 50%. But for real, let's say you reduce obesity by 50%, right? All these huge fast food chains are going to plummet, right? I think there's already not studies, but analysis on different markets, and they saw different food articles, how their sales lowered ever since Ozempic came to the market. So a lot of these industries that are making money off people that are overweight are going to tank if this becomes very readily available to everyone. And also, there's medical practices and surgeons and everyone that make their money off obese people. And if this drug comes in, right, and it's available for everyone, a lot of industries are going to suffer. So it's in their best interest to demonize Ozempic and spread it that it's terrible for you. It gives you thyroid cancer and you're going to get this and that. And because if this gets widespread, they're screwed. So, I mean, if you're McDonald's right now and that a lot less people are coming in and your numbers are dropping because of this one drug and you see the trend, I mean, what are you going to do? Just go bankrupt? No, you're going to try to potentially demonize what's causing your business to fail.
You bring up a good point, though. I mean, there's sometimes candidates or patients that come into my practice, for example, that I don't think would be good candidates for things like Ozempic. Like one of them came in and said, I really want to try Ozempic because I want to be able to go to Popeyes every single day. And they
No,
thought it
that's
was a
ridiculous.
license for them to be able to eat anything they wanted and still lose weight. And again, the psychology has to be there, the motivation. What are your motivators to? It's not Walmart medicine. And
Well, look, like
excuse me for
I'm
using
still
that.
going to the gym. I'm still training, doing
Exactly.
cardio, and I'm still eating well
Exactly.
every day.
Yeah.
I'm not eating sugar. I'm not going to McDonald's. I'm doing everything that a bodybuilder would do.
Exactly.
But it's just a tool to help me.
And that would be
not
an
be hungry.
appropriate tool for somebody
Exactly.
like you and other patients that I have. Again, short term, long term, that remains to be seen as far as my particular practice. But yeah, no, I think it's an excellent tool. I think it's really helped a
very
lot of my
exciting.
patients.
Yeah.
I love it when I'm canceling prescriptions for patients for blood pressure meds. I think it's a great day. And I mean, they're so excited. They're thrilled to bring in their home blood pressure recordings and show me that now it's low. We got to start stopping some of their meds. Their cholesterol levels are better. I mean, it's just, honestly, it's
miracle
life
drug.
changing for
It
a
is.
lot of
For me,
patients.
it is life changing, and I've always kind of struggled with weight my whole life. And I had a grip. I got a grip on it in my early 20s, and I still struggle with eating crap here because I focus on my business too much and my athletes
Yeah.
and not myself, and I don't find time for the gym when I probably should. And
When you're in the air,
yeah,
you know, how
I
many
travel
hours
40
a week?
weeks a year. It's very difficult to diet, and it's still an excuse. But now it gives me more time, more control, and I could feel much better, and I make the time to go to the gym, and I feel more motivated to
Your
go.
workouts are probably more efficient too because you're in there muscle building, resistance training. You're not in there doing 3 hours of cardio at the same time to achieve the same thing.
And I'm not as my cravings are way down. I used to love chocolate all the time. I don't eat chocolate at all anymore. I don't eat garbage. I don't eat fast food. I eat 1 or 2 meals a day till I'm satiated, and then I continue working, right? And I have a lot more energy. There's just so many. Anyways, we could talk about Ozempic on semaglutide all day, but I love this. It's a new thing, and it's very exciting, and it's demonized now for specific reasons, but it's definitely going to be an exciting future, not just in bodybuilding, whatever, but just in the whole world. It'd be nice if there's a lot less people that are obese, and there's a lot more health, and it's going to put a lot less strain on our medical system, especially in Canada where it's like a public system, and there's going to be a lot of benefits to it, I think, with this one.
Yeah, for sure.
drug.
As long as there's a good support system around it as well, I think it's one of many tools that we now have, and it's nice. It's rewarding as a physician to be able to help patients, or at least to witness their transformations and all of these reversal of some of their chronic diseases. It's a rewarding time to be in medicine, in my opinion.
I'm at Pure Muscle and Fitness, and every single person that's seen me today is, "Oh my God, you look so much leaner. I don't even recognize you." Every single person I've talked to is the first comment they say, and I'm like, "Listen, I'm still training and doing cardio and eating my food, but semaglutide is what helped me get to that point."
Yeah, for sure.
And so let's go into the next topic. So I want to talk about the challenges that family doctors face with bodybuilders and their blood work markers, right? Because we see that a lot. I send you blood work sometimes of athletes, and you look it over for me, and
Anonymously.
always. But bodybuilding is demonized, right, in the public medical system. If you go to your doctor and you say, "Listen, I'm taking this," they're like, "Oh, no, you're gonna die. Your liver enzymes are elevated. Stop this. Don't eat that much protein. Don't take these supplements. Don't." It's demonized. They don't want to hear nothing, right? And especially in Canada, in the States, you actually have some hormonal doctors that specialize with bodybuilders. But if you go to your family doctor, it's very rare that they're going to listen to you and want to help you continue to reach your goal if you're taking PEDs or you're dieting and getting too lean, instead of just trying to tell you that you're about to die and you should stop everything you're doing, and you know what I mean? So
Yeah, I think as a responsible family physician, I think I would feel the same way. My advice to patients who are taking PEDs would be to not take PEDs. I mean, that would be my standard response to anybody. However, they are making a choice. They've obviously listened to somebody, and if they don't know anything about the PEDs they're taking, if I have any information that I want to impart on them, I would certainly give them that information. So I don't necessarily judge them for what
no,
they're
of course,
doing.
it's not their fault. Their goal
Right.
is to make you as healthy as possible.
Yeah. But at the same time, they still deserve good health care despite what they're
Their
doing.
choices,
right?
right.
And so it's like patients who have, I'm not comparing an alcoholic to an athlete, so please don't. But people who know the risks of some of the health choices that they're making and they decide to take them anyway, you don't write them off as a patient.
smoker or
You don't
anything,
say, okay, if you're smoking, I'm not going to look after you. I'm not going to do any chest x-rays or CTs to check for lung cancer. You're on your own. They still deserve good health care. So let's say a patient's coming to me, they've made a health decision, such as maybe being on some of these performance enhancing drugs. And there are things that I would want to do to mitigate some of the symptoms that they might be having from some side effects. effects. And then there might be some investigations I'd want to do to make sure that any risks they have or they may potentially see as a result of taking some of these medications, that we minimize those for the hopefully short time that they're going to be taking them. For example, patients who are taking testosterone, tren, that kind of thing. We want to look at things like hematocrit for looking at their blood thickness. If they're a male, you want to look at PSA to make sure that their prostate doesn't enlarge too much. Ask them about any urinary symptoms, these symptoms that they might have. Women, they may start to have some of the masculinizing side effects. I may point that out to them and just say, you're already starting to get these.
You have a lot of bodybuilders that come to you?
I have a couple now. I have more and more that people now know that we treat them.
The difference between you and a regular family doctor is they can't recognize any of those things because they don't have the experience with it, right? And that's the point. You're an IFBB Bikini Pro, so you understand a lot of what goes on behind the scenes, right?
Yeah.
If you have a normal family doctor and they have all these side effects and their liver enzymes are higher, their hemoglobin or hemocrits or RBC is too high, they won't know how to mitigate this while continuing.
Or they might panic, like you said, whereas we know that's short-lived. I'll ask them if they did legs the day before they did their blood work, and sure enough, they probably did. So that's why their liver function tests are elevated. But the other markers of liver function, like their GGT or their bilirubin, for example, are normal. So I know it's just because of they're using their muscles. I don't get too excited. I mean, there are some outliers, right? There's some that are just so high that I say, okay, doing legs.
Or something.
This is not doing legs. There's something else. And sometimes just because they're on PEDs and they're asking for blood work, we may uncover something that they didn't know that's been going on insidiously for, I don't know, some time. So I think it's worth it to test. You have to ask yourself, what are you going to do with the test when you do it? So I don't do unnecessary tests. I don't just say, here's a full panel of blood work, go and have at it. And
if you're my doctor, that's what you do though.
Yeah. I never really understood that. Some of the anonymous blood work that you've shared from time to time with me, and I see these full panels, and sometimes I honestly, to be honest, I don't know what some of these markers
from
are.
Portugal and Taiwan, you're like, I can't speak.
Yeah, first of all, I sometimes can't translate it. But I think the issue is that you've got to be very focused on what you're looking for. So that requires somebody to take a good history, to examine the patient if that's what they need, and then order the appropriate test. Because I'm not just going to order any test. We're always going to find an abnormal test. It's silly.
In the Canadian healthcare system, blood work is very hard to get because the doctors, it's a liability on them. If you discover cancer in a patient, they're your patient after you're explaining to me, right?
So if you've developed a therapeutic relationship with a patient, meaning you've met them, you've gotten their health card, you're billing the government for your service, they are your patient until they're not your patient. So if they have an abnormal blood work, you're sitting on it with them. Medical legally, it's a risk for you, but it's also a risk for the patient. Like, you've got to inform them, and we've got to work towards a solution or refer them to the appropriate person.
There is a lot of doctors that just refuse to just offer you blood work unless you have symptoms, right? Which is what you're saying, which is it's reasonable in some senses, right? If someone's abusing the system, right, since the public system here, I get it, but some just refuse to. They don't want anything to do with it. No, I don't want you to be my problem if there is a problem, and it's also not a great medical practice either, right? What do you think?
I agree. I think that there's patients who abuse the system that just want their blood work every 6 months for no reason at all. And then there are patients where they're trying to get blood work and they're running up against some of these brick walls. And I think there's everything in between. And I think if the patient is honest with their physician, which a lot of the athletes are not, then the physician would likely make a decision to test blood work, for example, depending on the medications that they've said that they're taking. But a lot of times, I'll get some patients coming in and they're like, oh, I have these young guys coming in from the local gym and they're like, oh, I just want blood work. I just want to check some things. And I'm like, you've got to give me more than that. First of all, I'm not going to tell anybody. It's a therapeutic relationship. I'm bound by privacy laws, but you need to be honest with me. You need to tell me what you're taking. You need to tell me how much you're taking. I may say, wow, where did you get that protocol from? I don't know much about this, but I know.
But this is the value that you had. But if someone says, I'm on clenbuterol, you'll know, okay, maybe their cardiovascular health is at risk or There's could be side effects to that because it's a stimulant.
Sure.
But if you go to a family doctor, they don't even know what that word is.
No.
You know what I'm saying? And so it's a very hard
Well, at the very
relationship
least,
to
I
have.
think if they don't know, a lot of good physicians will look it up and say, I don't know the answer right now, but I'll get back to you and I'll tell you what I know.
In the best case scenario.
You know what? Our particular system in Canada, we probably wouldn't have the time to do something like that, to be very honest with you. But I think there are some doctors that have a reputation that know a little bit about some of these protocols and know a little bit about some of the medications, and like you said, have been through prep themselves. They understand what it's like to go through that deplete phase and all that kind of thing, and they would understand why this blood work would reflect that. I think just finding a good physician that would do that. The problem is that there's nobody that'll just give you blood work and then say, oh yeah, your liver is abnormal, good luck. So I mean, it's tough because then you've got to develop a relationship, you've got to carry them with you, and some clinics just aren't set up to do that. But your primary care physician should be the first place you go. And I think if you're honest with them and you say, listen, it's been my coach is telling me that patients, that other athletes that take this medication are getting this type of blood work done, I think you'd probably get a physician that would be more apt to test for that. They may panic when they see the results, whereas I may not panic as much because I know those levels are transient. I never say, oh, it's abnormal, forget about it. I always say it's abnormal. When you're off your protocol, if and when you're off, which I hope you do, then I will retest you 3 weeks later, that kind of thing.
Exactly. I had a family doctor when I was on taking steroids. I'm like, can we test my testosterone? I want to see what my free testosterone is in my labs. And he's like, why do you want to test testosterone?
I would ask the same thing.
You would ask me why I want to test my... Yeah, but if I'm taking... I was a young kid, right? I was 22 years old. I didn't know what I was doing, but I wanted to just see if I was healthy, right? And he would not give me blood work, even though I told him I was taking every steroid under the sun, just for even him to look at it, right? I didn't have resources like I have now. If it was my family doctor, I want to say, hey, I wanted you hear on the podcast, oh, you check your blood work. You don't know what you're looking at. But I was a young kid, and I was like, let's look at my blood work. Let's see what. He said, oh, why? You don't have symptoms. You're fine. I'm like, I'm taking all this shit that underground. At least offer me something.
But again, the appropriateness of tests. So I would never test somebody who's on test. I would never test their testosterone level. It's going to be high. You would hope it's high if you're an athlete.
So I have a urologist now that's testing all my stuff, and we're trying to manage, like my testosterone was too high, and I was taking like 200 milligrams a week because on TRT, and we're trying to balance.
Okay, that's different. TRT is different than pulse, like cycles of test.
But we're trying to manage my levels where it's optimal, where I feel good, and the testosterone markers are not too high where I'm having RBC, elevated RBC, and all that stuff.
Okay, you're trying to hit a therapeutic window.
Yeah, exactly.
That's different. Yeah. That's more long-term TRT dosing to try and match symptom control with toxicity, for example, or other markers if your hematocrit's high or your PSA is too high. Yeah, that's a little bit different. But somebody who comes in to me and says, I'm on a handful of PEDs, I'm doing this, that, and this and that. 5,000. Of course I'm not going to test their testosterone while they're in their peak of their cycle. I mean, of course it's going to be high. I would think that would be the goal of the coach and the athlete. First of all, I'm like, make use of it because hopefully you're going to come off of it soon.
It's almost like getting when girls get their labs done when they're like 3 weeks out from a show. Your markers are going to be fucked, guaranteed. Even if you're a natural athlete, doing all that cardio, being that lean is not necessarily healthy. And
they haven't got a period yet, and they're asking for their estradiol level. I'm like, why would you do that? Yeah. We already know because you haven't got your period yet that your numbers are out of whack. And to me, it doesn't matter what the numbers are. It matters it matters whether or not your homeostasis has returned. So your natural menstrual cycle, any symptoms a man might be having as a result of prostate enlargement, hopefully has gone down.
I always like to have athletes get blood work like before a cycle, and then 5 to 6 weeks after they come off their PEDs to see if exactly they're back at their baseline, the regular state. That's where you can find any health concerns, or let's say a girl comes off PEDs and she has like liver issues, like bad liver issues, and then there could be an issue, but you're not going to really be able to solve the situation if her liver enzymes are very elevated while she's taking, oral steroids or PEDs or SARMs. There's nothing much.
Well, my answer would be stop doing it. And are you going to stop doing it?
No,
exactly.
You're 3 weeks off from a show. And
right.
Sometimes girls get blood work 3 weeks out. My doctor said to stop this. And
again, don't do a test unless you know what you're going to do with the result. If you're prepared to do something about an abnormal result, then we'll do the test. But if you are just doing it just to know, I don't know why you would put yourself through all that extra stress. And I certainly, as a primary caregiver, don't want to hold on to a blood work that looks ridiculous.
Disaster,
yeah,
yeah.
like a disaster.
That's going to happen though when you're close to a show, like 95% of the time.
Absolutely.
If you're natural or if you're enhanced, almost guaranteed.
Renal function gets a bit compromised at the end. But you think about bodybuilding in the context of other very high level sports. We don't test necessarily. I mean, some of the professional sport athletes do in anything like, I don't know, wrestling or skiing, downhill skiing, or something where there's a lot of physicality at the end. They're training really hard for that one day where they got to do that one race or whatever. I mean, everybody's kidney function's slightly compromised at that point. Their liver functions are screaming because their muscles are tense. Their CK levels are through the roof.
Even a better example, like an MMA fighter, right? When they're trying to cut weight for a show.
Right.
Take their blood work 2 days off from the show, even before they do a water cut. It's going to be a disaster, even though they're natural, right?
So we just have to be very careful about when we do tests and what we do about it. So I would never tell an MMA, for example, 2 days before their show, I mean, unless they're in Florida failure. But again, they would know that because they would be unwell. Like it wouldn't be, I feel great and their kidney function is ridiculous. Like I just don't see that happening.
The one biggest concern that we see in bodybuilding as far as blood work is liver enzymes being elevated, right? Yeah. And that's where the family doctors freak out. They think you're going to have liver cancer and liver failure and you need to stop everything.
Alcoholic.
But what they don't understand is that there's many components that could attribute towards it being having elevated liver enzymes. Like I say training, right? You're breaking down your muscle, right? And it's
pigeon storages are coming. Yeah.
And then there's also having an elevated protein intake, which bodybuilders are going to do. Taking even natural supplements can increase your liver enzymes, right? And what they do the same thing every time. Come off all your supplements, stop this. And they don't understand that even just the fact that you're going to the gym and you're training hard and you're breaking down the muscle tissue and repairing it, it's gonna cause your liver enzymes to elevate. And of course, oral PEDs are gonna elevate it even further. But the second it's out of range, the doctors think you're dying and you're going to liver failure because it's not normal. Because they're not used to, not doctors like you, but normal family doctors are not used to looking at the labs of athletes that are going through this, right? They're taught in school, this is the markers, this is the average person, right? It's like the Ozempic studies. They're very like narrow-minded and in a funnel where this is what it needs to be regardless of your circumstances or what you're doing. So,
but sometimes you'll hand me a number, a cut of a small portion of an anonymous patient's, one of your athletes' blood work, and I'll say, let me guess, she's X number of weeks out from a show, blah, blah, blah. And you're like, yes.
You nail it almost every time.
Because it's just, you can see some of these changes that happen physiologically and biochemically throughout that whole cycle.
There's been a circumstance where they're like, are they on PEDs? And like, no, they've been off for 3 months. You're like, okay, we need to resolve this situation. We're like, she's not going to be taking PEDs for the next 6 months and maybe even opt for injectable PEDs eventually in the future instead of oral to reduce the, I don't want to say the damage, but the functionality of the liver, right? Because the injectables,
I'm not the one that would make a recommendation about
PEDs I'm not
saying,
hey, Kelley, what's the steroid protocol for
what would be the protocol? No, I don't
never
get involved in any of that. However, there's been a lot of, I talk to coaches too, and I have a lot of athlete friends, and a lot of coaches will say, it's been our experience that when you see this certain lab value, that it may be better for that particular athlete to do a short cycle of a higher dose testosterone, for example.
That's what I was thinking,
as opposed to drawing out a longer cycle of many weeks on a SARMs, for example. Again, I don't know where they're getting their evidence for this, and I don't know where the rationale. There certainly isn't any studies on that. So again, I think it's more just word of mouth experience, that kind of thing. And when you have hundreds of athletes, you kind of are starting to gather your own data.
Yeah, there's consistency with the lab works and exactly what you're saying. We're like, okay, this person's this many weeks out.
And I think we've started to see a few trends together in some of these.
Sometimes there's very basic answers to different lab work. So you're like, this girl needs to drink more water. Like very basic, or sometimes they take a lab work, right, and they're fasted. Right, so I say if you're like completely fasted and you have no like electrolytes in your system, the
BUN or the urea would be very high, for example. Exactly. Or the other thing is consistency. If you're going to do blood work, let's say we're tracking something, somebody's tracking something, and you did one blood work, you went and did legs and you went to the lab and you did blood work, and then the next time you did blood work, you didn't go to the gym for 4 days.
Yeah, whatever.
I mean, your levels that you're not comparing apples
now. Exactly.
You're not comparing apples to apples. I would say do what you normally do and get your lab work done around the same conditions at the same time all the time. If somebody's doing serial blood work for, again, whatever reason, I wouldn't change up your protocol and then do your lab work.
I had a bodybuilder message me the other day because I posted that I was doing on my private stories that I was doing bloodletting. And what that is, basically, it's like donating blood. And I do it privately. I have a nurse come to my house once a month. She takes 500 mLs of blood. And what it does is it reduces your hemoglobin, your hematocrit, and your RBC counts a little bit, because you have, I think, how many liters of blood do you have in your body? I think it's 6 liters, 5 or 6.
Yeah.
So you take a little bit, and then your body reproduces the blood naturally, and it's gonna allow your blood to not be as thick as it would, as far as just as a health aspect, because I'm on HRT. And then bodybuilder was like, "Hey, are you taking your tests always fasted?" And I'm like, "Yeah." He's like, "Next time, drink a liter of water and have a quarter teaspoon of salt. You're gonna see your hemoglobin and everything is gonna be in range." And he's a bodybuilder, he's on all kinds of gear. And I'm like, "Fuck, you're actually right." I'm like, "I always take it fasted." I'm like, "You're smart." It's true though, because.
But if you always take it fasted, then you should always take it fasted. Like,
Yes,
I wouldn't
yes.
necessarily change it.
But I'm saying if I'm always taking it fasted, right, and the marker's always off. And let me give you an example, right? If I do drink the 1 liter of water and I take the 1/4 tablespoon of salt or whatever, and my blood work is perfect, then.
But you're doing that protocol to get perfect blood work. You're not doing that protocol for your health. Do you know what I mean?
Yeah, but which one is the accurate one?
I would say the one you do when you're just out living your life doing all the things you normally do. I wouldn't do something special for the test. Again, it speaks to taking that out of context.
A liter of water is not really like, let's say I take the test fasted at 9 o'clock in the morning, and it's my hemoglobin is up a few percentage points over like the maximum, right? And then I take it at 12 instead, where I would just drink and eat normally.
But that's your normal hemoglobin variability throughout the day or throughout a life cycle of a red blood cell. Like, I just would not do something special to do blood work, because that's the abnormality. That's the outlier, and you don't want that. You want to know, when I'm just doing my thing, following James's diet protocol, workout, all that kind of stuff, what does my biochemistry look like? That's the question you want to answer, not what did I do to prepare for my blood work? How many liters did I drink? Because that's not normal. You're not, because the very next day,
I know what you're saying. I know what you're saying, but what is the correct? Should I? I know you're not going to say, but should I aim for my blood work to be perfect 24 hours a day, or because it's not going to be? Right?
Then don't do the blood work at all, because you know that there's variability. I would just follow what you're doing. That's not good science to prepare for your blood work in any way.
Let's say my blood work is perfect at 12, and my hemoglobin is a little bit high percentage at 9.
So what are you going to do? Bloodlet at 9 then, not at 12?
No, that's not, but just with the water that I'm drinking, like, which is the correct number? Between 9 or 12.
24 hour, what you do in 24 hours, not what you do at 9, not what you do at 7:30. What does your day look like? And does Monday look the same as Wednesday? Does it look the same as Sunday? That's the most important thing, is to be consistent in your diet, your exercise, your life, and your blood work. I would not do anything special for it, because you're just going to skew, and you're going to give yourself a false sense of security. I mean, it's really not realistic.
It can do the opposite too. So let's say your blood work is not perfect because you're dehydrated, right? And you think that your levels are off.
But I wouldn't tell somebody to just drink a liter of water before their blood work. I would say you need to drink an extra liter of water every day, because chances are you're just not getting enough. With one point in time, one blood work, it doesn't tell us very much. What we like to look at, if it's necessary, and again, if it's indicated and necessary, we want to look at things as trends over time. That's what we're interested in.
My urologist is like this too. He's like, stop trying to micromanage your blood work, because I have patients that are neurotic like you. You don't need to do this. I'm like, leave me alone. Let me enjoy my life.
Hey man, you do you. But I don't think that it's necessary, and I think it's skewing your blood work, because if you were able to plot all of your hematocrits over time, you may see these kind of weird outliers, and all they are is the fact that you prepared for it.
There's some things where I know right away where my blood work is gonna be at, just based on how I feel, right? So that would be maybe a measuring point where I could actually get blood work. So I felt like I was a little bit estrogenic, and because I was like holding a little bit more fat in my legs, it was weird. Something was off, and I did test my blood work. My estrogen was a little bit high. I think I sent that one to you. And then I took some exemestane, whatever, and anti-estrogen every couple of days, and killed my libido. And I could tell right away, because I know my body. I've taken gear before, and I've looked at the consistency throughout my blood work, that my estrogen was way too low. I knew right away. I got blood work, my estrogen was like 0. I'm like, I'm stopping this right away, because I felt that side effect from that. That was a good use of getting blood work, because then I stopped right away. I went to the urologist. He's like, yeah, don't take this. We're gonna manage we're gonna work on just your testosterone levels and where you feel the best, and your libido is high and you feel healthy. but your blood work is also in a good range.
I would use the blood work scenario in the second point that you made, not necessarily in the first.
Yes.
I think if you took a drug, you had a symptom, stopping the drug would resolve the symptom.
Yes.
I don't think you needed a number to tell you that
I
it
get
was
it every
low.
4 weeks anyway.
You felt it any.
Yeah, I'm like, I want to just confirm that I know what I'm talking about. That's why I did it. I knew it.
So I think you're the perfect example of, we either do blood work because we're looking for something or somebody has a side effect, and that would be the more indication to do any test, really, not just blood work, but any test.
All right. Yeah, because I already had solved the issue before I even got the blood work.
Exactly. So who cares what the level was, really?
I did.
If it was normal,
I felt happy about it.
But I guess my question is, if you still had low libido and your estrogen level was normal, would you still not stop the drug?
Yeah, I mean, yeah.
Yeah. So you didn't need the number to stop
No, I
the
didn't
drug.
need the number
You
at
just
all.
needed
I
the
stopped
symptom.
it. Yeah, exactly. I took the blood work and I stopped it right immediately afterwards, and I was like, okay. And then I felt perfect 10 days later. Anyways, let's get to the next question. Someone asked, how do you rebalance your hormones? And I spoke about this with you a little bit right before the podcast, and you were saying that it's such a vague question, and which hormones are you talking about? And a lot of girls want to know, how do you rebalance your hormones? But there's so many different nuances with the person and where you are in prep and after. It's a very hard question to answer, right?
It is. That hormone word gets thrown around a lot. Adrenal hormones, adrenal suppression, adrenal fatigue, female hormone issues, and
cortisol too.
Cortisol, like all of that. And I guess my question is, what are the symptoms that patients are complaining of that somebody has told them it's your hormones? Because they inevitably got it from their gym partner or the coach or whatever.
Perfect example. An athlete just inquired with me 3 days ago. And I saw her physique and I saw her drug protocol. It was whack. And she didn't get stage lean. And I asked her to send me her diet or training cardio. And her coach said that she's like, oh, by the way, the athlete told me, by the way, I have a cortisol issue and that's why I didn't get lean. I said, that's not why you didn't get lean. So my coach told me this is why you didn't get lean. I said, there's nothing to do why you didn't get lean. It's because your diet's not good, your cardio is not good, and your PD protocol sucks. This is why you didn't. It's not because, but the coach insisted it was because of her cortisol, and this girl went crazy on blood work. Oh my god, my cortisol is high. How do I fix this? I'm never gonna get lean if I don't fix it. They focus all the attention on one thing that had literally nothing to do with her end result of not looking good on stage. And as you said, that those words are thrown around so much all the time for what?
And I think there's hormone changes that happen over time in a person's life. Like your hormone levels, natural hormone levels, are different than a guy 60 years old. Their natural hormone, like their testosterone levels, their estrogen, their estradiol, their progesterone, all of that.
Or even,
Similarly,
even people, like, let's say different athletes have much higher testosterone than other athletes. So how can you balance? How can you say how
endogenous
I balance my hormones?
testosterone is
exactly.
low? Or in women, if you're not having a cycle, then your hormones are off. But it may be because of all the dieting you've done, your lean, your fat percentage, all those kinds of things. The female athlete triad, where they get amenorrhea. And so I think you've got to balance your hormones by getting yourself back on track. Competition prep is short-lived. It should be. I mean, very few people, Ashley Kay aside, I mean, she's just a superhuman, can do this consistently, like, every weekend.
We also haven't seen her blood work either, right? So what if her levels are off? We don't know,
but
right?
Again, is she having any symptoms? Is anybody having any symptoms that warrant treating? Is that person's particular, not her goal, but is a person's goal to have a baby after they step off stage? Yes. Again, what does that mean, hormone imbalance? And I get irked by that question, that comment, and then they say, so test my hormone. A woman's estrogen, normal endogenous estrogen levels, will change Tuesday at 3 p.m. to Wednesday at 9 a.m. So are you going to do blood work every single day at It's silly to do blood work in a normal cycling woman. I mean, in a normal cycling woman, I'm telling you, your hormones are right where they need to be, right? Like they're doing exactly what they're supposed to do. Patients who have other symptoms, like they don't get their periods back several months after, that's a different story.
A lot of the effects are that is because their body fat levels stay too low.
Possibly.
So I had an athlete who was crazy. She's from Taiwan, I believe. She says, James, I always get my period when I'm at 55 kilograms. I never get it under 55 kilograms. And it's true. The second we jumped over 55 kilograms, period right away. And it was like she knew her body, but
that's
just
her critical.
She knew that her body fat needed to be at that level. And some girls, I remember I coached some Olympian athletes, and they still get their periods all the way up until their show. And some girls, they don't. The second they pass a certain threshold, they stop getting their period, right?
Yeah.
And I think it's a very general and easy answer. If you're doing things in a healthy manner and you're doing your cardio, your training, and you're dieting properly, and your body fat is not too low, your hormones are typically going to be balanced, right? Especially if you're having your menstrual cycle. But if you binge after a show and gain 40 pounds and you're like, how do I get my hormones back to stable? Well, you know the answer already, right?
Yeah. It's multifactorial. I think the short answer is that's not an easy question, and it
need
depends.
more information.
And just I guess my biggest pet peeve in this industry is when people talk about their balancing their hormones when I don't really know what that means. And if I don't know what that means, I'm not saying I'm the smartest person in the world, but honestly, if a physician who tests for hormones for very specific
How long have
hormone,
you been a doctor for? We didn't even
24 years. Yeah. So, I've been around the block, but I think the issue is that, again, appropriate tests for the appropriate scenario, and I need more information than just balancing
hormones. How do you rebalance your hormones?
And what symptoms are you having that you think your hormones are not balanced? Because I can tell you it might be something else, and maybe we should be looking at other things too.
Okay. Let's get into PEDs and fertility. So it's another general question. So would PEDs necessarily cause someone to be infertile, or from your opinion and your experience, what would you think?
No one's done any studies. I'm sure we all know that now. I mean, really, PEDs are very unregulated. They vary in their purity and dosages, protocols, duration of time. But I think the fertility with PEDs, I think it's safe to say that the longer you take PEDs, let's say as a female, for example, the higher doses, you may have some fertility issues down the road. You just might.
I had an athlete that joined my team a year ago, and she was taking very hard PEDs for 5 years straight without coming off once.
No sight. Wow.
I mean, and it's very hard. And I was just like, I don't care about having kids. Okay, great, because you're probably going to have a hard time. But it's like you don't have your cycle for so long, right? And then you're deregulating your body and your hormones for that long period of time. The chances are that it comes back is lower than if you're cycling. Let's say you do competition season, right, and you get back to a normal body fat percentage, you come off PEDs and you get your cycle again, right, and you rebalance your hormones. That's going to be a lot healthier than staying on forever. You don't have your period for 3 years, right? You got to be smart with what you're doing.
Yeah, and again, it's already such a black hole in general that the least you could do is speak to somebody with a reputation for having some experience with PEDs to understand what kind of cycle what's the maximum cycle I should do on this, for example. Or some people, like, they'll start to get the androgenizing effects right away, like the square jaw, the voice box changes, that kind of thing, after 2 weeks, let alone somebody staying on it for 12 weeks and they don't see any androgenizing side effects whatsoever.
It's so crazy.
Everybody's different, and it all depends on what you bring to the table when you go on these things, what your level of health is at that time, what your endogenous hormone levels are to begin with. Do you have any pre-existing conditions like PCOS, for example? Those kinds of things. It's a very broad thing. I think generally people's fear in both men and women is sterility risks in patients who take it for long times at high doses.
Yeah, but there's no...
Not to mention cardiovascular risk, osteoporosis risk. I mean, the list goes on. But I mean, if we're just talking about things with fertility, I think the name of the game is probably, and again, I'm not prescribing it, I'm not giving advice, is shorter cycles.
And make sure after your show you come off enough where you can get your body fat to a level where you can get your period back.
Exactly.
So your body, you can see that your body is naturally functioning properly, right?
Yeah, but we know lots of professional athletes that have children. And
marathon runner, even,
And so...
We were speaking about this before too, but look at all the top bodybuilders that want to have kids. Ronnie Coleman had 8 kids. He did a lot of steroids, right? And this is not a study or factual evidence, but every single one of my athletes that wanted to have a baby after the competitions, after done competing, and I've taken PEDs, were able to do that without any issues. The only ones that had issues afterwards is because they had issues before. Either they didn't have their period for 5 years before, and they regardless of before they even started training, or...
And they were 5 years younger back then. Exactly. You're also 5 years older. So if it's the difference between age 30 and 35, there's already natural hormone changes that are happening anyway. Yeah. The difference between 45 and 50 is huge. You could probably be menopausal in that time, even if you didn't do anything. Like PEDs. So the time in your life when you're talking, I'm not suggesting that they want to have kids, but in terms of returning to a natural cycle, your hormones are going to do their thing as you age anyway, let alone what you add to
I've coached hundreds of girls, and I've never once had one come to me and said, hi, doctor says I'm infertile now because of the PEDs I've taken or whatever. And I've had girls, they do a competition and a week later they literally get pregnant. I've had girls get pregnant during preps and have to drop out of prep maybe 15 times in my career right now. While they're 2 or 3 weeks out, hey, I'm pregnant. Or so many times, let's say 6, 7 weeks out and they're not losing weight and they're on estrogens and this. I'm like, what's going on? They're like, I'm pregnant. I'm like, that's the reason why. But so even while they're on PEDs, they can still get pregnant. It's a person to person dependent thing. And it's going to have a lot to do with how you were before you started bodybuilding, right? And how long are you taking the gear for? If you had problems before and you were taking gear for 5 years straight without any breaks, you never got your period for 5 years, I mean, you're kind of dumb, honestly. I mean, it's not very, if you want to have kids, right?
Yeah, I mean if this is just you want to do this for a set amount of time, this was your bucket list thing, you really wanted to do it, or you want to be a career bodybuilder, then that's a different story. I mean, then maybe there is less concern for those long-term side effects with respect to fertility. However, I'm sure those professional career athletes are getting regular surveillance done, regular blood work, just to make sure that there aren't any other side effects. So, I mean, yeah, that's my general thought about that, is that I'm sure over a long period of time at high doses,
with abuse, right?
Yes. Yeah.
Exactly. All right. That's very good, Kelley. TRT in women, if your testosterone is low, is that better to start off with TRT or go on PEDs? And can you just explain what TRT is quickly to
Sure.
listeners?
I'm going to back up one, and I'm just going to say the patient would come to me with symptoms, and then I would do their blood work. So I wouldn't just see a patient for a well woman visit, for example, and do their blood work and do a testosterone level. I wouldn't really have an indication to do it. The patient would tell me something like, my libido's a bit low, or I have low energy, I have muscle aches and pains, I'm in those sort of perimenopausal I've got those types of symptoms, and then I would do their blood work, and then I would see, let's say, for example. I mean, I've got to have a reason to do a test, as I said to you.
I gave shit to my family doctor because I shared this with my dad, and my dad, guaranteed his testosterone was low. He's tired all day, napping all day, can't do anything, has no motivation. Like, your testosterone is low. You're almost 60-year-old man. You have all the symptoms of having low testosterone. He refused to do blood work on him. And I'm like, I see his testosterone levels to maybe give him TRT. I'm just like, it's unfreaking believable. If I brought him to my urologist, your testosterone's way low. I'm just like, but they come to you with the symptoms and you're like, okay, this makes sense. Maybe you do have low testosterone. Let's do a test.
Right. Yeah. So, I mean, I have done that on patients who have come to me and patients who we were considering starting HRT because they may have vasomotor symptoms of perimenopause, for example, night sweats, hot flashes, some mood changes, that kind of thing. So it would be nice to know what their baseline is. And then again,
HRT, are you referring to testosterone or are you referring to other
estrogen and progesterone therapy, depending on what the patient's history is. Testosterone replacement in men is a lower dose of either a short-acting or long-acting, and you can get long-acting up to 3 months. Those injections.
I don't know if they prescribe short-acting.
Sometimes they do. I mean, it just depends on, in Cayman, when I was working in the Cayman Islands, they prescribed a lot of short-acting, like injections as TRT. It was just an interesting, it was very...
Is it short-acting or is it the longer ester ones just being administered every day in micro doses? Because
both.
They do that here.
You're right. So you're absolutely right. So there was some where they were microdosing over several days. They would do a 5-on-7 protocol or a 2-on-5 protocol. But then there was another one where they were actually using primidone. I guess it depends on how short acting you think that one is, as opposed to Nebido. For example, Nebido is, I think, 3 months. It can last one injection every 12 weeks or something like that. So, I mean, so there's different protocols for, and it depends, this is where real hormone specialists, physicians who do a lot of endocrinologists, for example, or a lot of hormone specialists. The doctor I happened to work with in Cayman had a special interest in hormone therapy. So I actually learned a lot from him in terms of how to dose patients and things like that. And then whether or not they became to the feminizing effects of testosterone, the estrogen was unopposed, and the aromatization, that kind of thing. So balancing that out. I mean, I don't know if that's a specific answer for a specific patient, but I mean, I would start out by just asking the patient, what are the symptoms that they are having problems with? That may warrant checking their levels, but not just testosterone, but estrogen, progesterone, like 17-hydroxyprogesterone, LH, FSH. Those are all very important blood work to kind of look at in the context of that. And then we would either start oral therapy or transdermal therapy, depending on a patient preference or whether or not they have any liver issues where we want to bypass that. And yeah, I mean, it would really depend.
The medical system, though, is very different in the States, and they have these hormone clinics
Yeah.
that they give testosterone there to anyone you want. You could be a 12-year-old like, I feel like a man, I'm going to get testosterone. And here it's a lot more regulated, but in the States, like a lot of times anyone could get testosterone. These females are getting testosterone. That's like the base. Oh, every girl's getting testosterone that starts bodybuilding over there. There's a lot of teams where they have a doctor on a team and everyone's getting testosterone as opposed to just starting on Anavar or whatever you want to start on.
Yeah, it's interesting because what they're looking at is the relative increase or decrease in their testosterone at any given time, as opposed to a hard, are they testosterone deficient or are they not? So they're not looking, so presumably, because I've seen this, the patient will come in or the girl will come in and their testosterone will be normal, in that normal range, right? Between this number, and depending on which country you're in, we're using different units of measurement. But relatively within that normal range, she's on the lower end of the testosterone. So there's a justification that kind of goes on to say, she's normal, we can push it a little bit, we can supplement, we can give her exogenous testosterone and get her in the normal range, but a little bit higher.
It's different. Yeah, you want to be optimal on the high end, or you want to be kind of in the average, right?
So then we're not really treating symptoms so much as we're trying to manage performance. Exactly. So that would be the rationale behind that. And then, of course, in that case, we would want to do blood work because there is a sweet spot there that I think that they're looking for. Again, I don't do this. I don't know much about it. It's a sport-focused treatment as opposed to a health treatment focus. And I'm not to say that the people that are doing it are not focused on health. I mean, their angle within a healthy person is to maximize sport performance, whereas the average patient that comes in to see me is more interested in just their symptom reduction and health. Yeah.
But it's good that there's outlets and private practices where athletes can go to where they have a doctor with experience with that. If that's their goal and they can do it as healthy as possible.
For sure.
Right. So
yeah, I think they're probably they're carefully monitored and it's all above board, and they're really they're scrutizing the blood work, and it's a comparison as opposed to a hard, are you deficient? Are you somebody who's got a low normal testosterone might, like your dad, for example, let's say his testosterone was normal, but it was at the lowest end. Chances are, based on his symptoms, he's still testosterone deficient relative to what he was. And the problem is nobody did blood work on him when he was 40 to know what his blood work, maybe his blood work was high normal before. So that drop in the normal range resulted in a lot of symptoms for him, for example. I'm speculating.
Yeah, exactly.
But that's, so it's more the relative increase or decrease as opposed to a hard, are you deficient, are you not deficient?
It's two different goals, yeah. I mean, you don't necessarily need testosterone as a girl to be injected in you just to be a healthy person, right?
You do not.
But there may be some situations where that could be the case. But,
sure.
But
on average, I don't know. I don't personally know any that I would say your problem is, although your testosterone's normal, you're deficient. Like I just have not done that. Again, I'm not an endocrinologist. I'm not a hormone specialist. But in my practice, seeing the patients that I do, that wouldn't be the first thing I jump to. And I would be amiss if I didn't check other things for their symptoms, because what if I'm missing something else and I'm just focused on your T is low normal?
Yeah, no, it makes perfect sense. So yeah, there could be a lot of other issues. It could be even no, exactly. Good point. Next question is just general. Someone just asked me to ask you about gut health, right? It's a big thing now. Everyone's trying to optimize their gut health, and you want to go into this a little bit and from your experience?
Yeah, I think you're going to hear a lot more about gut health. I think we don't know a lot about the gut microbiome right now. We know more and more every day, and I think it's a very interesting area of medicine and science that a lot of people are pouring a lot of research into. So I'm certainly not an expert to speak on this, but I think the importance of the gut microbiome is being discovered more and more with its relationship to chronic disease management, inflammation, things like that. I don't think we know enough about it to make a hard and fast, this is the problem and this is because your gut health is, your gut microbiome is off or whatever. But I know there are a lot of people that are studying it. I think
we were speaking about this at dinner with Rudy, and he just said that he was on the carnivore diet and he feels much better and a lot less inflammation, he's a lot less tired, and just based on his diet alone. So
I think diet is huge, and like other things like sleep and stress management and all that, can affect your gut microbiome as well as your general health. Whether or not that's the causal relationship, I think remains to be seen. So I think I wouldn't say it got to a point where people were using that word all the time that we are started to become very dismissive of it. And I think I'm starting to change my attitude with some of the legitimate research that's being done currently, and very humble, good companies that are saying, we don't know enough about this, but we're starting to see correlation here. That's not causation. We're just starting to see some of these observational studies. And so it's leading them to do a lot of mouse studies. That's a huge area of research in mouse studies for doing research on the gut microbiome. So I think it's going to be, we're learning more and more.
The mouse, the little bellies are checking out what's going on.
Unfortunately, they have to do them post-mortem, but yes, they don't live very long, but they live all for the name of science. And so I think it's exciting to know a bit about it. How people always ask, how do I manage my gut health during training? You know what? There's going to be disruption. I can tell you right now, the stress on the body, it's going to be, whether or not that's causing you some major health concerns, I don't know. I really wouldn't be so bold as to make that assumption, but a lot of things get disrupted when you're in prep. That's not a normal, so static state for any human being. And you just have to accept that your body's going to go through some things
Phases
as you
while
do
you're
it.
doing that, yeah. While you're doing the short-term dieting or being
Totally.
very
Restrictive in your diet.
Food, exactly. Yeah.
Exactly.
But some people do better on very restricted diets.
Yeah.
Rudy was just saying his life completely changed when he just was eating eggs and meat all day. That's all he eats.
And I think you have a lot of athletes that go on some of your diets and they feel better because they were eating literally like garbage before and after.
I spoke about this on one of my previous podcasts, but this is why I don't like the free-for-all if it fits your macros thing, because yes, at the end of the day, it is calories in, calories out, but how you feel and all like your micronutrients and everything, it's very important what you're ingesting and what you're consuming in your body, right? And it's not just calories in, calories out, yes, for fat loss, but it's everything else around it too.
Yeah, and your body is deplete and it needs those micronutrients during prep more than ever. Yeah, I could eat a 1600 chocolate diet versus 1600 calorie balanced diet. Calories in, same as calories.
You might lose the same amount of fat, but how are you going to feel?
Yeah, I mean, it's just, I really think we have to look at nutrition, micronutrients more so than macro. I mean, macros, that's your job, but micronutrients I think are just as important, just because your body's,
Can you
you're
test
putting
my micronutrients?
Yeah, my gut microbiome.
What symptoms do I have? I don't want to ask you for a test. It's going to be a nightmare.
I'll fight you for it. That's for sure.
Do you have any do you have any general protocols people could do to optimize their gut health? Not any specific situations, but you were mentioning maybe like some type of probiotics or other things, like glutamine or. I know you were saying there was no specific studies that says this is going to be the.
There's a lot of good probiotics out there. There's a lot of good probiotic companies out there right now that are being funded to do research. Pendulum is one that I happen to know of. I'm not sponsored. I just happen to think they're a really good company that is looking at the gut microbiome very specifically in respect to things like glucose control and other things, which I think has shown very promising results. Hence, now they've got supplements and probiotics that are being marketed. Again, not there to make claims about diagnosis, treatment protocols, or things like that. But we do have a lot of good research that's coming out with respect to probiotics. Prebiotics, so the food that the bacteria eat, lower sugar. They seem to, general consensus is that refined sugars may disrupt that more. So more balanced diet. Again, what does balance look like in the context of an athlete versus a normal person? I think generally I've been with you now for 5 or 6 years, and the diets that I think that you guys are putting out for prep are, to me, very well balanced. I don't have an issue with there seems to be a good variety of things when possible, and I know there's times when it gets
your fats
you
are
got to
low,
do
your
it.
carbs are low to get stage.
You got to do it, and you're eating one food group or two food groups for a while to get to the goal. But again, that's very short-lived, and it's very goal specific. It's not for. But I think the off-season diets are they're varied enough that I think that people would want for nothing in that outside of whatever.
Cheat meal here and
there.
Yeah,
cheat meal here and there.
Quickly, optimizing sleep, right? Sleep is such an important factor for recovery and just general health. Do you have any tips to optimize your sleep?
There's off-season sleep, and I think there's prep sleep. I think prep sleep can become disrupted with hormone changes, for example, workout, muscle,
Being hungry before bed.
being hungry before
Semaglutide.
bed, being stressed out. It depends on what you're doing when you're in prep. If you're working 3 jobs and you're trying to prep at the same time, I think sleep's going to be very disrupted. Calorie restriction can disrupt sleep. Stress management. There's lots of things. I think sleep is going to be I personally think it's one of the most important things that is a modifiable factor in health. Like there's so much of it that we can influence ourselves to improve sleep. There's so many things that reducing blue screen time, for example, not drinking caffeinated products.
There actually are a lot of studies on
Tons. And I think that, but more just realizing how important sleep is in overall health. Like risk factor reduction in cardiovascular health, dementia, huge in neurodegenerative, like looking at sleep deprivation, chronic sleep deprivation as risk factors for some of these later cognitive syndromes that are in older age. So I think sleep, if you can do anything for yourself, it's really to research your sleep hygiene, research your sleep patterns, and get it as good as it can be. It's going to change during prep, and it's going to suck at certain parts of it, like everything else. But make sure it's short-lived, and make sure you get yourself back on track, because it's good for recovery. I mean, you want to talk about muscle recovery. You don't need half of the crap that you drink, like BCAAs and all that stuff. If you just get a proper night's sleep, you're going to have all the recovery that you need, at least in the off season on a regular.
The question is like, well, how do I optimize my sleep during prep when I'm 3 weeks out and I'm on 1,000 calories? I mean,
it's going to be compromised.
Yes.
You're going to do the best you can. And again, it's good quality sleep too, right?
Waking up
some
every
people
30
take
minutes,
medication to sleep, but it's not necessarily stage 4 non-REM sleep, for example. That's the restorative sleep intervals. I mean, it's going to be difficult. And I think it's like anything else. It's short-lived. Get yourself back on track, and then you'll be good after.
All right. Kelley, I think it's going to take us to the end of this podcast. I really appreciate your time and your insight as a bikini pro and a doctor. And
thank you.
I hope this information serves as some value to you guys. If you have any questions for myself or Kelley, please leave them in the comments below. And I definitely want to have you back on for part number 2, because I feel like there's a lot to discuss. So
you bet.
Thank you very much, Kelley.
Much.
So.